You're watching Healthbeat, Bikasisa's monthly television program. I'm Mia Malan. The United Nations says men who have sex with men, sex workers, transgender people, injecting drug users, and prisoners are groups of people particularly vulnerable to HIV. These populations need health services the most, but health workers tend to discriminate against them, and that discourages them from using health facilities. The result is that they don't have adequate access to things like condoms, HIV prevention pills, or antiretroviral treatment, making the virus spread. If taken correctly, HIV prevention pills can almost wipe out your chances of contracting HIV through sex. And people who are HIV positive and take their ARVs regularly cannot infect others, as the medicine reduces HIV in their bodies to levels too low to infect others. Later in the show, I'll be speaking to the Treatment Action Campaign and the Health Department about how to change the system. But first, journalists Mohali Malloy and Yolanda Mtzeki met two trans women who say a routine visit to a government health clinic can be a hostile experience.
Beyonce Mabena is a trans woman. That means she was classified as male when she was born, but she identifies as a woman. She's often been misunderstood when going to government hospitals.
Back in 2007, I was sick. I was having tonsils. And I went to a public clinic. Then immediately when I arrived there, they greeted me with smile and everything. And it was fine until I provide my ID document. Then when they opened, they said, oh, but you have a name for guys. Why do you have a name for guys? Why a lady have a name for guys? I said, that's my bad name, and there's nothing I can do about it, but you can call me Beyonce. Then they started to laugh.
The experience made her determined to change things for other trans people.
Public health should be where we can run to, and we are a community that is in high risk of getting HIV.
Luyanda Mzimela has had similar, horrible experiences. Using government clinics often makes her feel worse.
I felt like I was alienated. I felt like I was not human. I felt like, have you heard of human zoos that they had back then? I felt like one of those little girls or that African women there in European countries, and they just look at me like I'm an animal.
Luyanda and Beyonce work at the Aurum Institute's pop-in clinics in Gauteng. They make sure transgender people and other groups with a higher chance of getting HIV feel safe.
Immediately you come, you are greeted with a smile. Like it's a lovely place to be. It's a safe space. You can talk about anything. You can be yourself. Yeah, if a public clinic can create a space where you become yourself, not pretend to be someone else.
It's important so that people will come back. You come back and get the medication, especially the ones who are on ART, which is ARVs, because we want to retain them, make sure that they're healthy and they're very low risk, and also for our ladies to come back and get their HRT, to get their beautiful.
HRT, or hormone replacement therapy, is a medication that helps transgender people develop physical traits closer to the gender they identify with. Problem is, it's not always available.
And you might get to a clinic or hospital where they just don't know what you're talking about.
Oh, great. How are you?
They both know that attitudes aren't going to change overnight. That's why they give workshops at clinics and hospitals to educate staff about trans people.
We go around the province and we sensitize people in clinics and hospitals. Basically, from the gate to the general workers, to the staff nurses, to the professional nurses and the doctors sometimes. So the whole clinic comes in.
Despite how she's been treated, Beyonce believes that people can change if armed with the right information.
We shouldn't judge them also. They are human, they are allowed to make mistakes, and if they are not educated about something, so why should we judge them? But if we give them education, then they still continue. It means something wrong with you personally. It means you hating this community.
At the end of the day, it's all about respect.
Don't focus on how I look like or my aesthetics. Do I look androgynous? Why am I wearing a skirt whilst I have a beard? Just treat what I'm here to ask for treatment for. That's all.
Facing discrimination in health facilities is not unique to transgender people. Richichi, an organization representing people with HIV, recently surveyed 9,000 people from population groups with high HIV infection rates. Researchers asked them about their experiences at hospitals and clinics. With me to discuss that is James Oladipo, one of the authors of the report. James also works for the Treatment Action Campaign. James, thanks for joining us. Which groups of people did you survey?
Thank you for having me. Yes, we key populations, which includes people who use drugs, sex workers, transgender people, and gay, bisexual, and other men who have sex with men.
So if you were, for instance, a drug user or a transgender person, were you refused care?
Yes, out of the people we interviewed, at least 12% of the interviewees were refused services. And the most highest number of people that were refused services were amongst people who use drugs. Next, transgender people. There were about 9% of the trans people that we interviewed that were refused services. And the sad part is that majority of those people that get turned back or refused access never got services anywhere. So they end up just going home or just leaving with whatever issues that they went to the facility to resolve.
We've spoken about health workers, but what about other staff at hospitals? For instance, security guards or porters. Did they discriminate against these populations as well?
Clinical staff were, the nurses were top on the list of those that were being unprofessional and disrespectful to staff. But then coming after that is security guards, because you should know that security guards are the first point of call when people access the healthcare facility. So security guards, and again, like, cleaners were also people that key populations found that they were discriminatory and disrespectful. You have issues like key populations like trans people being denied access to bathrooms, telling them, oh no, telling a trans woman that you're a man, you should go use the men's bathroom.
If we look at the consequences of such treatment, what is the effect on those patients' willingness to then seek treatment after such an incident?
We discovered that quite a number of key population also no longer access healthcare services anywhere, which means they've disengaged from care, they do not access preventative services anywhere. They've just decided not to go because they can no longer take such disrespectful and feeling unsafe in the healthcare facilities. So issues like that are some of the consequences or repercussion of this discrimination. But also on a national level, we as a country, this also affects the HIV response, because key population are the vulnerable people that are much at risk of HIV infection. So if we leave key population behind, then we are losing in our fight against HIV.
James, let's move on to solutions. How do we fix this?
Again, this year we've asked that the National Department of Health establish 2 centers of excellence, 2 specialized clinics in each district per key population group. So what this means is that a clinic where each key population can go to in their district, where they can get a full package of services that they would require, and also plan patient transport, because we know districts are vast. So there are issues around key population not being able to access this clinic.
James, can you give us an idea if you say a full package of services, say for drug users or for transgender people, what would those packages look like?
The responses to a person that uses drugs is different to a trans person or to a gay person. So, for example, for a trans person now, they will need a clinic where they have access to contraceptives, access to hormonal therapy, access to counseling, access to post-violence services in a space that is respectful and non-discriminatory. For a sex worker, they will need a facility that provides services like post-violence services, contraceptive, post-exposure prophylaxis, that where they will get offered PrEP every time they go for HIV testing.
Do you think the health department has the resources to put those up?
Well, based on the commitment or the presentation that we've listened to about the specialized clinics, there will be one specialized clinic in each district for all population group. But we are saying that is not enough, because you cannot train people and create services for every population group in one clinic. It is just too limited, and we would like to see at least two.
Talking about access, your study also found that over 60% of transgender people wanted to have access to hormone therapy. Is that available at government clinics, or is there a problem?
Hormone therapy is not available in most healthcare facilities, only in the bigger cities. So what our study found out was that 63% of trans people wanted to access it they would like to access it at their public health facility, because then it's closer to them. It's where they go for their basic health care. So it would be ideal for them to be able to access it there. But what we also found out is that 43% also were not even provided the information on where to access it.
James, thanks very much for your time today. That was James Oladipo, one of the authors of Rishichi's report on the state of the healthcare of key populations. The health department says it knows about the discrimination against groups with high HIV infection rates at clinics, and it has training programs in place. Joining me via Zoom to discuss how those training programs work is the acting head of HIV in the National Health Department, Dr. Tatu Chidarekiri. Tatu, thanks very much for joining us. Who gives this training? Is it the health department, or do you contract it out?
It's both. Health department has regional training centers, but a lot of our partners have training units. So most of the dissemination is through partners, but the Department of Health also does some training.
So if you could just break down this training for us, what is it that you teach health workers that lead to the change in their attitudes?
So we developed a curriculum. So it's a training curriculum. It has a participant's manual and a facilitator's manual. So it's a full curriculum. And what we train on it is, well, the first few chapters have introduction to basic HIV, symptoms, the basic information. And then as you move through, it actually starts talking about how to actually deal with clients, and especially key populations, our different types of key populations. We have our LGBTQ, we have our sex workers, we have our MSM, but basically to say, do you know the difference? Do you know if one says, I'm presenting as MSM, do you know what that means? So that they know, how to respond as healthcare workers and how to manage the situation.
Just to clarify for our viewers, the MSM that Tatu referred to here is men who have sex with men. Tatu, let's apply this information that you've given to a specific example. Let's, for instance, say there's a doctor who sees a transgender patient and argues that the transgender patient is just confused about their identity. What would you do to change their attitude and treat the patient properly? What is it that you're going to teach them specifically so that they don't discriminate in that way?
So the good thing about this training curriculum is that it has video clips.
There are challenges that they meet,
and it actually has individuals, live individuals with experiences. We do have a chapter that talks to transgender persons, and we have an individual, a transgender person, who talks about their experience in the facility. For example, there's an individual who comes through. She's a trans woman. So she went into a facility for circumcision, because remember, trans women born men and then is transitioning. So she comes through and the doctor says, but we don't do that with women. So she has to now explain that I'm a trans woman and explain what that is. So going through that, it's like then the doctor then goes out, another doctor comes in, you know how they will go in and out. It's basically in the curriculum itself. It's a very good example of now somebody saying, almost like doctor says, come and experience what I'm experiencing. And she is there and she's trying to get a service that she's trying to get.
Earlier in our program, we spoke to an author of the Ritsitsi State of the Healthcare Report for Key Populations. And one of the recommendations of that report was that the health department should have sent out by the end of February a circular to all clinics that would explain that people coming from populations we've discussed with high HIV infection rates should never be refused healthcare to clinics. Have you done that?
I can confirm that that circular was signed because I signed it. It was signed and sent out.
Have you had a chance to investigate any of these cases of discrimination that the researchers told you about in their report?
So as national, where we are sitting or within my office, we have not necessarily gone out to investigate per se, because implementation goes on or happens at a district level within the provinces. Then that's where the investigations are supposed to go through. What we do is we follow up to look at what the challenges were and whether the challenges have been, especially the systems challenges, because that's where we have power. And then, for example, if a report says there hasn't been any training or trained nurses, we will ensure that there is capacity building.
So if a worker is found guilty of discrimination against one of these groups, what would happen to them?
There would be, as we say, an investigation and then the root cause, because that's where we start. To give an example of KZN province, where we went to facilities and we would talk to healthcare workers and say, so what do you think about the training? What is happening now? And you would find that, a healthcare worker would say, I did not understand the transition because this kind of information is something that I was never exposed to. Or that judgment of a sex worker or a man who has sex with men. That's what we are saying. No, you don't judge because it's not even your job to judge. Not that anybody has a job of judging, but as a healthcare worker, that is not even part of anything. You give the services that you need to give without any judgment.
Dr. James Oladipo, who we spoke to earlier in this program, pointed out that many people, the majority of transgender people who they interviewed, said that they wanted access to hormone therapy. But this therapy seemed to only be available at large institutions in cities, and in rural clinics, they really struggle to access it. How can you change that?
This is a specialized therapy, and it's not the kind of therapy that you get over the counter. It's scheduled, and it also needs support, a psychosocial support. So that is why it's in specialized facilities like your tertiary hospitals. So what we may need to do, right now we are saying that we should bring services to the people, just like our national strategic plan, our HIV plan, actually says it's more kind of like community-centered, community-led. And as we move towards 2030, we want to ensure that every individual is brought into the services, into care, self-care even. We would be able to, move other interventions towards the communities. However, when one thinks about moving an intervention that out of a clinic or a hospital into the community, we need to be able to talk about the infrastructure, the training. How is that going to be done in a safe manner? So it is work in progress. I'm not going to be saying it's never going to happen, but it is work in progress.
Dr. Tato Chidarakiri from the National Health Department, thanks very much for joining us. We hope you found our show today interesting. Until next time, goodbye.